Now we can move for the next speaker, Professor Karim Elmasri, gynecologist from from Emirates. He will talk about us to chemotherapy GOG 213 trial.
Good afternoon, ladies and gentlemen. Thank you very much. I'd like to thank the organizing committee for inviting me here today. I would like to congratulate Professor Basil for an amazing conference. But not only that, it's actually, I think, probably a record for MEMAGO. This is the very first, okay, yes, Muhyiddin, yes, you're waving, and to you, Muhyiddin, always Muhyiddin. No, but this is the first MEMAGO that has actually run on time, and I would suspect it's probably the first meeting in Egypt to have run on time. So that actually, if I would like to say, deserves a round of applause. Okay, so Dr. Ala, excellent presentation. I would like to now explain why I do not think it's the standard of care. So let's see what we all agree on. We all agree that surgery with chemotherapy is the standard of care for the initial management of ovarian cancer, whether this is primary debulking surgery or interval debulking surgery. We also all agree that about 60 to 85% of patients will unfortunately recur with their ovarian cancer. So what are the treatment options at that point in time? It's a combination of either chemotherapy, surgery, hormonal, immunotherapy, or targeted therapy. So the ongoing question that we have is there a role for secondary cytoreductive surgery for the treatment of recurrent ovarian cancer? So as Dr. Ala has alluded to, we've got three studies, which is Desktop 3, SOC1, and the GOG 213. So my emphasis initially would be to talk about GOG 213, and then I'd like to compare it with the other studies, Desktop 3 and SOC1. So GOG 213, this was looking at secondary cytoreductive surgery in platinum-sensitive patients who were surgically amenable to surgery, and to see whether this would improve overall survival. It was a phase 3 multi-center study, international randomized control study with intention to treat. The inclusion criteria was similar to the other two studies of a platinum interval-free period of 6 months or more. Difference here between this, which I'm going to discuss further, was that this was an investigator-determined resectable disease. The randomization was 1-to-1. And in terms of the chemotherapy, it was either paclitaxel with carboplatin or gemcitabine with carboplatin plus or minus bevacizumab as seen appropriate by the physician. The primary endpoint was overall survival. The secondary endpoint was progression-free survival. So the target enrollment was 485 patients, deemed under all the necessary statistical things, and recruitment started in 2007, took about 10 years, and the data collection point was in 2019. The two arms were well balanced in terms of the patients, and I'm going to go through that in a second. So 240 patients were assigned to the surgical arm, of which 225 patients actually did undergo surgery. 15 actually eventually declined to have surgery. One patient was also taken off that because there wasn't enough surgical data included, so they were excluded. And complete gross resection was 67%. Now, what I'd like to point out is the low incidence of aborted procedure, which was 4%, a low 30-day morbidity of 9%, and a mortality of one patient within 30 days of surgery. What about the chemotherapy? So for those patients who did not undergo surgery, the median time to starting chemotherapy was 7 days. Those that underwent surgery, it was 40 days. 84% of patients had a concomitant and maintenance bevacizumab. That's an important point, and it's going to be important when we're comparing this study to the other studies. So 84% received bevacizumab. Paclitaxel and platinum was the preferred combination of choice for the chemotherapy and was given to 70% of patients. There was no adverse events. And these were the results. So, on the left-hand side, this side, this mic doesn't reach me, I have to bend forward. So, the median overall survival for those who underwent surgery was 50 months. For those who underwent no surgery, just chemotherapy, it was 64 months. So the hazard ratio was 1.28%. If you look at the progression-free survival, which was the secondary endpoint, for those patients who underwent no surgery was 16.2 and 18.9, with a hazard ratio of 0.82. So the conclusion of the study was that, based on the hazard ratio, was that there was no benefit in patients having surgery followed by chemotherapy for recurrence of their ovarian cancer. How does this compare with the other studies? So this is the comparison between the GOG 213 with the desktop 3 and the SOC1. They had a very similar platinum-free interval. They looked at the complete gross resection. The adjuvant treatment was all platinum-based. If we look at the patients, there was similar age distribution. The main interest, which Dr. Ola quite rightly alluded to, was that GOG 213 was different to the AGO and the SOC1 in that it was individualized, so it was up to the physician to decide whether this was surgically resectable or not, compared to the AGO model, AGO criteria, or the I model and a PET CT. So the SOC1 actually used I model and the PET CT. Again, a similar distribution in terms of the histopathology. What about the surgical side? So GOG 213 achieved a complete gross resection rate of 67% compared to higher percentage for the AGO and the SOC1. However, as Dr. Ola said, is that the crossover to surgery in the SOC1 was significantly higher. What about chemotherapy? This is an important slide because actually there's a significant difference between the GOG 213 versus the bevacizumab and the SOC1, in that the majority, 84% of patients, receive bevacizumab. So, this is what matters, overall survival. How does that compare? Well, the interesting thing is that the surgical arm was fairly similar across all three studies. So the surgical arm was overall survivor, GOG 213, 53 months, AGO, the desktop 3, 53 months, SOC1, 58 months. The difference really comes in the no surgery arm. So that's where the outlier lies. What about our secondary endpoint, which is progression-free survival? Well, again, it's fairly similar to all of them for the surgical arm, but the no surgery arm, again, this was different. This is an outlier. So remember what we said, that the complete gross resection rate was somewhere between 67% for the GOG 213 versus 74% for the SOC1 and a similar figure for the AGO. So what about if we just focus on those patients who achieve complete gross resection? Does that make a difference? Is that why the GOG 213 fell short compared to the others? Well, actually, no, it wasn't, because for those who underwent surgery, again, fairly similar. And the chemotherapy, the issue is that the chemotherapy arm in GOG 213 is way superior compared to the other two trials. And what was the difference in the chemotherapy arm? The difference was that those patients, 84% of patients received bevacizumab. But remember that these studies were done predominantly in the area before PARP inhibitors. And also there was a limitation in terms of bevacizumab. So Dr. Ola's statement that surgery is the standard of care is true, providing that we do not have access to bevacizumab or PARP inhibitors, or we're not doing BRCA testing. But today, when we do have access to bevacizumab, I would not really agree with that statement that surgery is fundamental to the management of secondary ovarian recurrence. So looking at all three studies, the criteria for selection was fairly reasonable, but it was better with the desktop 3 and with the desktop 3 and the SOC1 compared to the GOG 213. The impact of surgery was fairly remarkably similar across all three studies. But the outlier, as we said, is the use of bevacizumab. So actually we have to, in a way, restart again all our studies because this is no longer valid. It's useful data and actually shows that it's fairly remarkable, but it's no longer valid as we head for 2024. And with that, I'd like to thank you.